Heart transplantation refers to the surgical placement of a healthy donor heart into a patient suffering end-stage heart failure in order to restore normal cardiovascular function and save the recipient's life. It remains the only definitive long-term treatment for select cases of severe systolic heart failure, not controllable with medical management or assist devices alone. Almost 4,000 procedures occur annually worldwide, with over 1,200 in the United States. 1-year survival approaches 90% given major immunosuppression advances. A failing heart struggles meeting metabolic demands of body tissues, potentially progressing into a relentless downward spiral towards end-stage heart failure, featuring profound exercise limitation, fluid retention, breathlessness, and eventual death despite maximizing medical therapies. Common conditions underlying heart failure include ischemic cardiomyopathy, prior heart attacks killing muscle mass; dilated cardiomyopathy, enlarged weakened chambers with poor contraction; viral myocarditis, inflammatory destruction of heart tissue; muscular dystrophy types damaging heart muscle cells; chemotherapy cardiotoxicity; hypertension inflicting chronic workload; heart defects creating abnormal strain patterns. Temporary ventricular assist devices can postpone transplant in many cases, but definitive heart failure requires replacement to avoid multi-organ failure, kidney dysfunction, and eventual expiration. Transplant furnishes a new functioning muscle engine, resuming sufficient cardiac output meeting physiologic demands. Since transplantation risks prove substantial with open chest surgery, exhausted treatment options, and poor projected survival often tip decisions towards attempting transplant's possibility of full activity restoration, despite needing lifelong intensive care and immunosuppression to avoid catastrophic rejection. Careful patient selection weighs risks and benefits. The complex heart transplant procedure requires seamless execution across identification, procurement, implantation, and post-operative management stages, recipient selection and waiting list. Heart transplant candidates face stringent medical and psychosocial evaluation determining eligibility for waitlist inclusion. Advanced age, cancer, infection, obesity, pulmonary hypertension, diabetes, peripheral vascular disease, or neurologic issues can exclude candidacy given surgical mortality risk or impaired outcomes. Social support systems assess capability managing lifelong stringent post-operative care. United Network for Organ Sharing (UNOS) then prioritizes status 1A/1B registrants by urgency. Advanced age, cancer, infection, obesity, pulmonary hypertension, diabetes, peripheral vascular disease, or neurologic issues can exclude candidacy given surgical mortality risk or impaired outcomes. Social support systems assess capability managing lifelong stringent post-operative care. United Network for Organ Sharing (UNOS) then prioritizes status 1A/1B registrants by urgency. Donor screening and cross-matching. Most donor hearts derive from brain-dead cardiovascular injury victims able to oxygenate organs until procurement. Donor tissue typing detects candidate compatibility markers. Unsuccessful match predicts hyperacute immunologic rejection. Virtual cross-match simulations help allocate organs, though false positive computer predictions still occur. Timely transportation within 4 to 6 hour cold ischemic window proves vital, preventing deterioration. Surgery. After midline sternotomy incision exposes mediastinal structures, surgeons carefully dissect heart connections, sparing phrenic nerves, resect failing atrial cuffs, but retain ventricular muscle mass and excise all cardiac tissue possible, preserving sinus node elements if viable. The new heart implants next, suturing left atrium cuffs, pulmonary artery vein remnants to donor counterparts. Aorta and pulmonary artery anastomoses follow with heart reperfusion and reanimation. Temporary right ventricular assist insertion tides function until the organ stabilizes. Chest closure proceeds, leaving drainage catheters helping manage post-op bleeding with careful fluid management. Immunosuppression. Powerful induction agents like interleukin-2 receptor antibodies confer early immunosuppression, preventing hyperacute and acute heart graft rejection from tissue mismatches. Maintenance regimens including calcineurin inhibitors, cyclosporin, tacrolimus, block T-cell activation and proliferation, while antimetabolites azathioprine, mycophenolic acid, suppress lymphocyte activity and proliferation long-term. Side effects require extensive monitoring, dose adjustments, and infection vigilance. Some centers now trial infusion of mesenchymal stem cell or T-regulatory lymphocyte cell types to potentially induce donor immune tolerance, allowing tapering of pharmacological agents. Post-transplant care. Early post-operative milestones include cognitive status, renal function, rhythm stability, and ejection fraction quantification via echocardiography. Frequent biopsies screen for cellular or antibody-mediated rejection, while coronary angiography visualizes graft vasculature integrity. Medication levels necessitate regular checkups, adjusting dosing with side effect and rejection surveillance long-term. Supportive self-care education facilitates necessary lifestyle modifications and emergency plan fluency, essential for years of intensive management, avoiding threats to graft survival from infection to sudden arrhythmic events. Types of heart donors. Orthotopic heart transplantation incorporates the complete healthy allograft organ, replacing all cardiac tissue, while alternative variations spare certain native cardiac elements or utilize device assistance. Donation after brain death, DBD. Most organs, including approximately 60% of hearts for transplant, derive from patients formally declared brain dead, while cardiopulmonary systems remain functional on life support. Multiple physicians verify absent brainstem activity through clinical tests and imaging over hours, but circulatory physiology continues, allowing perfusion of downstream organs. Living will or family proxy consent enables surgical retrieval, arranging operating rooms and procurement teams. Hearts flush in situ on bypass to quickly cool and deoxygenate tissue before heart-lung block removal, reducing reperfusion oxidative damage. Machine preservation tides function until implantation. Living will or family proxy consent enables surgical retrieval, arranging operating rooms and procurement teams. Hearts flush in situ on bypass to quickly cool and deoxygenate tissue before heart-lung block removal, reducing reperfusion oxidative damage. Machine preservation tides function until implantation. Donation after circulatory death, DCD. Improving DCD potency now salvages hearts in donors failing resuscitative efforts, from whom families authorize non-heart-beating donation once circulation ceases, over 2 to 5 minutes, to ensure no auto-resuscitation chance. Rapid cooling and minimally invasive ECMO restoration of donor circulation preserves viability in eligible recipients despite longer ischemic times, up to 4 to 6 hours until transplantation, if sufficiently cooled. DCD provides another 15 to 30% annual heart grafts, otherwise unfeasible, expanding donor pools. Living donation. Rare procedures transplant half a healthy living donor's heart, typically in pediatric cases, surgically splitting the organ along septal margins, leaving adequate function in both patient and recipient. Outcomes usually excel given instant availability and implantation, almost abolishing ischemia time, but living procedures remain extremely rare, only performed in specialized centers, given risks to a live volunteer. More research refines patient selection for this possibility. Artificial heart implantation. Completely implantable total artificial hearts, like the syncardia, serve as a life-saving bridge option in biventricular failure when biologic graft availability lags. This biomechanical pump sustains circulation until transplantation, avoiding multi-organ failure. Challenges include stroke risk from anticoagulation needs and device malfunction jeopardizing survival until a donor heart becomes available. Still almost 1,200 left. Right or biventricular assist implants occur yearly, aiding recipients. Xenotransplantation. Given perpetual human heart shortages with long waitlists, newer options like genetically engineered pig hearts with knocked-out complement activation factors successfully transplanted in baboons and primates reach over a year, demonstrating feasibility. While still experimental, xenografts could provide unlimited organs in the future, pending immunological barriers and infectious transmission risk assessment. Genome editing technologies continue advancing this application. Early safety trials may enroll patients in upcoming years if preclinical efficacy extends. Future directions. Tissue engineering aims to eventually bioprint or regenerate fully functional autologous heart muscle from patient stem cells or matrices, avoiding rejection, though still investigational. Customized pumps, subcutaneous intravascular turbine assist devices, or synthetic mesh wraps strengthen native damaged tissue. And pharmaceutical options targeting molecular pathways show promise, interrupting adverse ventricular remodeling or inflammatory processes, perpetuating muscle dysfunction. Integrated device drug biologic solutions will continue advancing care. In summary, heart transplantation can prove life-saving for end-stage failure patients, yet requires significant aftercare and immunosuppression to sustain function. Expanding acceptability criteria and alternative donor organ options strive to allow its applicability to more recipients in future.